Hello, my name is Régis Paulinelli. I'm a breast surgeon and oncoplastic surgeon from Brazil. Thanks to Dr. Régis NL for the invitation to this webinar. I will talk in the next 40 minutes about breast cancer prevention and treatment of breast cancer and some facts, myths and hopes that we have to have in the case of breast cancer. According to the World Health Organization, cancer is already the leading cause of death worldwide. We had around 10 million deaths in 2020. Both Brazil and India face a high cancer death toll. There were 2.26 million breast cancers in 2020, according to WHO. Breast cancer is the leading cause of death in most countries, including Brazil and India, especially among women. The incidence of breast cancer is lower in Eastern countries and higher in Western countries. But in India, 34% of women with breast cancer will die of it. In Brazil, 15% will die. In developed countries like the United States, only 12% will die. How could we reduce breast cancer incidence and mortality rates? There are some interesting theories about carcinogenesis. This one is very illustrative. As cells multiply, mutations can occur. Mutated cells usually have the defect corrected or goes into apoptosis. Like here, they die. Apoptosis means die. However, some cells can survive and accumulate other mutations, which leave the cell unstable and more susceptible to new mutations. These mutations give cells superpowers, such as escaping cell death, multiplying faster, inducing blood vessels, penetrating tissues, and finally migrating throughout the body and surviving in other organs, generating metastases. Some people are born already with a mutation and have a higher risk of developing breast cancer. Reducing breast cancer incidence is called primary prevention. This way we could prevent some breast cancers to occur. What are the main risk factors for breast cancers? There are many risk factors for breast cancer. Some of them we can't change, like being a woman. Women have 100 times more breast cancers than men. Incidence rates increase with age. Breast cancer is 6 times more common after 50 years old than before. India and Brazil have a relatively young population, but life expectancy is getting better. So we expect that breast cancer incidence may increase when our population grows older. Family history is also important, and some cancers may be caused by pathogenic mutations, genetic mutations, like those occurring in the BRCA1 and 2 genes. But every woman should be cautious about breast cancer. 70% of breast cancers occur in women without family history. In Brazil, 1 in 10 women will get breast cancer. In India, a little less. In Western individualized countries, 1 in 8 women will have breast cancer. Hormone factors are important. More exposition to female hormones is related to more cases of breast cancer. So early menarche, late menopause, prolonged hormone therapy, for example, could increase breast cancer risk. Breast cells differentiate with pregnancy and breastfeeding, so women without children and getting pregnant after 30 are more susceptible to breast cancer. There are some premalignant breast lesions that work as markers for breast cancer risk, as the atypical hyperplasia. We still can't change our ages, our genetics, family history, or the age of first period. Women nowadays have fewer children and delay the age at first birth. But if we change lifestyle, up to 68% of breast cancers could be prevented. Preventing obesity is mandatory. We could reduce 32% of breast cancers this way. Obese women produce more female hormone in the fat because an enzyme called aromatase. We can simulate physical activity and breastfeeding. Alcohol intake is also related to breast cancer. It's also well established that a healthy diet rich in vegetables and fibers can reduce breast cancer. If we're able to identify high-risk women based on family history and genetics, we could also use medicines like tamoxifen to reduce breast cancer incidence. For some women with pathogenic genetic mutations, there is a possibility of risk-reducing surgeries like oophorectomy and mastectomy. But as I said, 70% of breast cancer survivors don't have a family history. High-risk genetic mutations will be found in just 10% of breast cancers. Early diagnosis or secondary prevention is very important. Here you can see the survival curves according to the stage of the disease in 10 years. If we find in situ carcinomas before they invade tissues, 98% of the women will be cured with surgery alone. And the mortality rates increase with tumor size and lymph node involvement. Unfortunately, in the case of metastasis, most women will be dead in 10 years. So, early diagnosis is important in reducing mortality and preventing more aggressive treatments. Here you can see the results of the more important screening studies using mammography. In the 70s and 80s, some randomized studies were conducted. At that time, researchers randomized if women would get a mammogram or not, if it was ethical at that time because we still didn't know the real benefit of breast cancer screening programs. Almost all the studies showed the great benefit of biennial mammograms after 40 years old and especially after 50s. On average, there was a 25% mortality reduction in the screening group. It's important to know that ultrasound and MRI doesn't replace mammography. They can find other missing cases of breast cancer, especially in women with dense breasts, but they increase costs and distress because they find many suspicious benign lesions that will need biopsy at the end. Both ultrasound and MRI have high false positive rates. I don't believe we will have a new randomized study. It would be unethical nowadays. We already know the importance of mammographic screening programs. This recent Swedish prospective study with more than 500,000 women showed a great survival benefit in serial participants of the Swedish screening program. In comparison to those less adherent, that would skip the mammogram sometimes, and much more in serial non-participants. Serial participants had 50% less risk of dying in 10 years than non-participants. Those who believe in mammographic screening are from time to time haunted by ghosts of the Canadian study. Once in a while they release a new analysis of their study with updated follow-up. They haven't found survival benefits in annual mammography, and they stated that 22% of screen detected breast cancers were overdiagnosed. They believe some of these tumors would never develop or lead to death. There are many criticisms of this study. It was conducted in the 80s when mammograms were getting popular because of other studies' results. Scientists believe that some women in the control group got their mammograms done. Experts have mostly suspected issues with the randomization, which they say would skew the findings. When interviewing 28 staff members who worked on the original study, some confirmed there were multiple instances in which women with detected lumps who were pre-screened by the nurse were in fact purposefully placed in the mammography group. The same could have occurred in high-risk women who were willing to have mammogram. Actually, not all cancers detected by screening programs will have benefits. There are some tumors like tumor A in this graphic that may be less aggressive, especially in older women. Surely some women would have died from other diseases without the diagnosis of breast cancer. On the other hand, there are some very aggressive breast cancers like tumor D in the graphic that would appear as metastatic disease, even with annual mammograms. There are still others, like tumor C, that would progress after an early diagnosis, despite the screening and treatment. Only women with tumor B diagnosed in the early stage and cured by treatment will get the benefit. For a screening program to be effective, there are some conditions. We should be able to identify the disease in apparently healthy individuals. We should recall the patients to do their exams. In the case of suspicious findings, there should be a quick access to diagnosis and treatment. And for a breast screening program to be effective, more than 70% of the target population must participate regularly. You can see here that the current recommendations for breast cancer screening are conflicting. The main world institutions don't agree on when it should begin, at 40, 45 or 50, or the periodicity, annual or biennial, when or if it should end. Studies with self-examination didn't show benefit. There were more benign findings without reducing death. Clinical examination is still controversial. The Brazilian Society of Mastology still advises self-examination and clinical examination because we don't have in Brazil, like in India, a structured screening program. It's only an opportunistic screening. Doctors just ask mammograms when women come from routine visits. Unfortunately, more than a half of breast tumors in Brazil are found by the women themselves. When they come to our office, we advise an annual mammograms at 40s and up to 75-year-old, or more if the women have a good life expectancy. In a 20-year study, clinical breast examination conducted by trained female health workers in Mumbai led to a downstaging of breast cancer at diagnosis and reduced mortality from the disease by nearly 30% in women aged 50 or older, but with no mortality reduction seen in women younger than 50 years. Clinical breast examination should be considered for breast cancer screening in low and middle income countries because of that. Although we aren't a rich country, there is a reason why we believe our women should begin mammography screening at 40 instead of 50. Our population in Brazil is much younger than that of the developed countries in Europe and North America. The same is true for India. Because most women are young, most cases of breast cancer occur under 50-year-old. If we recommend beginning mammography after 50 years, every 2 years, ending at 70 years old, as suggested by the public health system here, we would find less than a half of breast cancers. If we could perform a mammography in every woman annually, after 40 years old, we could detect almost 90% of breast cancer. There is more than 70% necessary for a breast screening program to be effective. Many women in our country rely on the public health system. They face difficulties in finding a doctor, in having a mammography. We are far from the ideal. Only 60% of women between 50 and 69-year-old in Brazil had a mammogram in the last 2 years. You may have heard about BI-RADS. It's a report, organization and quality control system in the United States which standardizes the terms used to describe lesions, divide them into categories, of risk of malignancy. It's nowadays used in many countries. Depending on the category, different actions must be taken. Category 1 is normal breast. Category 2 is benign. For example, simple cysts, intramammary lymph nodes, implants, lipomas, stable post-surgical changes, calcified fibroadenomas, stable fibroadenomas after 2 or 3 years of follow-up. The woman should repeat mammogram according to the screening program by age. Category 3 is probably benign, like a round circumscribed solid fibroadenoma, complicated cysts, coalescing microcysts, monomorphic clustered calcifications. In this case, the woman should repeat the mammogram after 6, 12, 24, and 48 months. After 2 or 3 years, the lesions are reclassified as benign. Categories 4 and 5 are suspicious. A biopsy must be done. Category 6 is a biopsy-confirmed malignancy. Category 0 is also of concern. There may be 5% rate of malignancy in this group. In this case, an ultrasound or special mammograms incidence should be performed for better assessment and to be able to correctly classify the case in another category. There are different histological types of breast cancer. Initially, precursor lesions may appear, such as benign proliferation lesions, known as B3, that increase the risk of breast cancer. Don't mix up B3 lesions with the BI-RADS category 3. Then there will be the development of the in situ carcinomas and finally invasive carcinomas. In situ carcinomas are limited by the basement membrane and have no capacity to cause death. Not all in situ carcinomas will become an invasive lesion. When carcinoma becomes invasive, it can infiltrate tissues, blood vessels, and lymphatics, and ultimately metastasize to other organs and cause death. Breast cancer cure depends on early diagnosis, quick access to breast surgeon or breast oncologist, and adequate treatment. More money is being spent on chemotherapy and new drugs. It's very important, especially for locally advanced breast cancer. But 80% of breast cancer will be cured because of surgery alone. Hormone therapy will cure 10% of the case. Another 10% will be cured because of chemotherapy and radiotherapy. It's very important that any woman with breast cancer have a quick access to treatment. Delays in starting treatment of more than 2 months are related to increased mortality. There are different breast cancer molecular subtypes. Luminal tumors are the most common. Express hormone receptors are sensitive to female hormones such as estrogen and progesterone. These tumors are less aggressive and tend to have recurrence and metastasis later. Small luminal tumors up to 1 and 2 centimeters usually do not need chemotherapy and are treated with hormonal drugs. Luminal tumors larger than 5 centimeters require chemotherapy treatment, and these treatments are usually done before surgery. They are called neoadjuvant treatment. For luminal tumors between 1 and 5 centimeters, there are genomic tests such as Oncotype DX and MammoPrint, which can tell which tumors should benefit from chemotherapy, and we can avoid these more aggressive treatments for less aggressive tumors or for those which do not respond to these treatments. HER2 tumors express this kind of protein, which has been the target of several new drugs, which has greatly increased the chance of cure. HER2 tumors larger than 1 centimeters requires chemotherapy, and those larger than 2 or 3 centimeters require neoadjuvant chemotherapy. Triple negative tumors are usually the most aggressive ones. They have been the subject of much research to discover possible therapeutic targets and new drugs, but they still have a darker prognosis. Even tumors up to 5 millimeters require chemotherapy, and tumors larger than 1 centimeter require neoadjuvant chemotherapy. These are some examples of therapeutic targets and drugs currently used in breast cancer treatment according to molecular subtype. I won't go into details because I don't think it's meaningful at this point. We can see it clearly if we compare breast cancer survival rates among women treated by private practice and health insurance with those needing to rely on philanthropic institutions and public health systems in Brazil. Poor women must wait longer for diagnosis, for screening, diagnosis and treatment. That's why they live less. The difference is still more evident in locally advanced breast cancer, in which the quick access to treatment and access to new expensive drugs is still more important. As I'm a surgeon, I will give you some idea of how breast cancer surgical treatment is. As I said, surgery is responsible for 80% of cures, but you don't need to be too aggressive. We have enough level 1 evidence to say that conservative treatment is equivalent to mastectomy. Here you may see 6 large randomized studies. Local recurrence and survival were similar in quadrantectomy and mastectomy. Sentinel node biopsies nowadays replaced many indications for axillary clearance, and it's a fantastic achievement because there is much less morbidity, like lymphedema and shoulder disabilities. There was an increase in bilateral mastectomy in the last decade because of fear, but for most women, the risk of contralateral breast cancer is low. A bilateral mastectomy doesn't impact the cure and survival. Breast cancer reconstruction is not the same as the natural breast. There is a much higher risk of complications and dissatisfaction. It's important that women and doctors be aware of it. I believe the only real limitation for a conservative treatment is our ability to leave behind a good cosmetic result and a good symmetry. These are some real patients that came to our service referred by other surgeons for a delayed reconstruction after conservative treatment. Nobody wants to have such poor aesthetic results. The 2 main tools that we have available for increasing the indications of conservative treatment are neoadjuvant chemotherapy and oncoplastic surgery. Neoadjuvant chemotherapy is safe, it reduces the size of the tumor, increases the rates of conservative treatment, and reduces the reoperation rates due to positive margins. We indicate it for any luminal tumor larger than 5 centimeters, and any HER2 tumors larger than 2 or 3 centimeters, and any triple negative tumor larger than 1 centimeter. For luminal tumors smaller than 5 centimeters, we try to order an Oncotype DX or mammoprint because 40% of these tumors won't need chemotherapy at all. The only point with neoadjuvant chemotherapy is that there is a small high risk of local recurrence, according to this meta-analysis. That's why it's so important to mark the tumor previously with a metal clips or ink tattoo. Usually you don't need to resect all the initial tumor area, but it's very important to evaluate its response if it was centripetal or scattered. I dedicate myself to oncoplastic surgery and breast reconstruction. I believe it's very important for women to keep a good self-esteem. There is a law in Brazil that guarantees that all women must have access to breast reconstruction. Still, only 40% of women in the public health system in Brazil needing a mastectomy will get a breast reconstruction. I believe the situation may be similar in other developing countries. We have a lot to improve, and our women with breast cancer deserve it. Here's how I plan my oncologic and reconstructive surgery. If possible, the best option is the conservative treatment. In this case, if I need, I do an oncoplastic surgery. Many patients don't need any kind of reconstruction. If I have to do a mastectomy, I try to preserve the nipple. If it's not possible, I try to preserve the skin. In many of these cases, it's possible to place an immediate implant. When the skin isn't enough or not of good quality, I try to place an expander. In case of previous radiotherapy, I prefer to use myocutaneous flaps for reconstruction. Lipofilling can somehow reverse some bad effects of radiotherapy over the tissues and sometimes allow for implant-based reconstruction. This meta-analysis of 61 studies showed that 5 to 15% of the patients are sorry with the decision. 15 to 19% are dissatisfied with the aesthetic results after 1 year, and it gets worse over time. 23 to 55% of the women think they look worse after surgery. 32% have psychological problems because of it. 23 to 45% experience a worsening sexuality. 45% loss of sensitivity, 70% pain and discomfort. Additional not planned surgery are very often, especially in the case of reconstructions. Women don't know it. When they ask us to do a bilateral mastectomy, they act out of fear. They think it could prevent the tumor to recur. It's our obligation to explain that a conservative treatment is as safe as mastectomy in most cases, and that usually the difference is just more risk of complications. Another important part of breast cancer surgery is the axillary management. Axillary clearance have been the standard for many years, but it's associated to many complications like seroma formation, lymphedema, paresthesia, pain, weakness, and shoulder restriction. Fortunately, things are changing. We are now in the era of sentinel node biopsy for most of our patients. Unless axilla is clearly involved, we may find the sentinel node using blue dye, radioactivity detection, or other methods. The sentinel node is the first group of lymph nodes that drain lymph from the breast. If the sentinel node is free, usually the others will be. Even in the case of escaped metastasis, the risk of axillary recurrence is very low, overall around 1% in any circumstance. After the Z11 study, even if there is 1 or 2 positive nodes after a conservative treatment, the consensus is not to proceed to an axillary clearance. The cumulative axillary recurrence in 10 years will be only 1.5%. The exception is in the case of a gross capsular extravasation. In that case, the recommendation is to dissect the axilla. After this study, there were other important studies like IBCSG 2301 that prevented axillary dissection in the case of micrometastasis in lymph node. INSEMA and SENOMAC validated the ECOSOG Z11 and included enough cases to mastectomy to prevent axillary clearance in these cases. After neoadjuvant chemotherapy, there is still a lot of controversy. If the lymph node was always clinically negative, it's considered to be safe. In the case of a positive node that became negative after chemotherapy, there's a higher risk of false negative results. Researchers are trying to reduce the false negative combining 2 methods like blue dye and technetium, resecting more lymph nodes or marking the positive lymph node with a metal clips, radioactive seed, or another method. As a matter of fact, axillary recurrence will be a rare event anyway. That's for today. I tried to bring together some important features of breast cancer prevention and treatment to give you guys a general idea. I hope it's been useful to you. At the beginning of the pandemic, I created a website to help colleagues and alumni interested in oncoplastic surgery. It's called oncoplastic.com. Now thousands of surgeons around the world are using the website as a learning tool. I'm very happy to be able to contribute in some way, and I invite you to visit it. I will make my presentation available there soon. Thank you very much for the opportunity to be here in India with you.